everyone, my name is Tilantana Baxter. I am a Columbus State University RNBSN student. Today I will be giving a presentation on an evidence-based practice project titled Reducing Falls in the Neurology Unit. First of all, let me introduce you to my co-worker, Pam.
Hello.
And the person who is filming is Chris. For this presentation, I am going to talk about the following topics: Introduction, Neurology in Patients, Falls, Objective of the Evidence-Based Practice Project, Reason for Evidence-Based Practice Project, PICOT question, research article number 1, 2, 3, and finally I will finish with concluding comments. Neurology in patient fall. First, how do we define a patient fall? According to the National Database of Nursing Quality Indicators, a patient fall is a sudden and unintentional descent to a surface, which can be a floor or some other object. For acute care hospital, patient falls occur approximately 1.3 to 8.9 falls per 1,000 patient days. Studies show that neurology units such as our unit tend to have even higher rates. Why is that? Because the conditions that make patient fall risk such as disorientation or hinder mobility are on our floor. Examples are altered mental states, psychological conditions, recovering from surgery, disoriented due to medications such as psychological medications, blood pressure medication, narcotics medication, and elderly patients that are weak and sometimes disoriented. What are the objectives of this presentation? The overall objective is to reduce the patient fall rate in the neurology unit. How will that be accomplished? First, it will be accomplished by achieving 100% compliance with the Prevention of Falls guideline by the neurology nurses and staffs. The second way is by improving our current fall risk assessment tool, the MOS fall scale, by supplementing it with the Johns Hopkins fall risk assessment tool. But the ultimate goal of this presentation is for the neurology nurses to change the way they think about patient falls. That will be accomplished by showing how important fall reduction is to the staff of the neurology unit and just how important fall reduction is to the neurology patients. Why is fall reduction important to the hospital? Here are 2 reasons. On average, inpatient falls on average increase hospital stay by 6.3 days. Average cost of an inpatient fall with an injury is $14,000. Why is fall reduction important to the patient? Here are 2 reasons. Can adversely change outcome for original hospitalization. Fall add stress to patients and their families. The neurology unit monthly fall rates always in top 3 among 16 units. Nurse and staff do not consistently apply prevention of falls, healthcare protocol guidelines, and fall risk assessment tool does not consider medications. This slide shows you statistics of fall on January 2016 to September 2016. And from the slide you can see that true north, which is neurology fall, the fall rate is 26. Okay, next, PICOT questions. The PICOT question for the evidence-based practice project is: in neurology unit patients, how does the Johns Hopkins Fall Risk Assessment tool compare to the Moss Fall scale in predicting fall risk patients over a 6-month period? This table is a risk factor comparison between the Moss Fall scale and the Johns Hopkins Fall scale. You can see that high-risk medication is a factor in the Johns Hopkins Fall assessment tool and is not a factor in Moss scale. Now, I will present 3 evidence-based practice research articles that support change in fall prevention in our unit. The first article is a multidisciplinary assessment instrument to predict fall risk in hospitalized patients, a prospective matched pair case study. This research was conducted in Methodist Hospital in Houston, Texas. Intervention for this article was to identify fall risk in patients using an assessment tool based on patient physical, mental, pharmacological, and metabolic data. Total population was 120 patients. 60 patients who failed and 60 control patients. Detail: in an 824-bed hospital, inpatient fall data was conducted in December 2009 to August 2010. Patients were interviewed within 48 hours of their fall to determine factors that led to fall. A model using 6 predictors of fall was used. Result: a fall risk assessment tool that evaluates a combination of physiological, pharmacological, and metabolic factors increase the probability of correctly identifying patients who will fall. So my thought for this research article is: the hospital currently uses the Moss Fall scale, which does not include pharmacological factors. The Johns Hopkins Fall assessment tool does evaluate pharmacological factors, so we should include it in our patient fall risk evaluation. The second article is Inpatient Fall Prevention Program as a Patient Safety Strategy, a Systematic Review. Intervention: the researcher performed a systematic review of articles detailing the betterment and damage of fall prevention program in acute care hospital. Sample: PubMed articles from 2005 to 2012. Detail: successful elements identified for implementing fall prevention programs included management support, inclusion of staff in development, committee oversight, small-scale testing of interventions, use of information systems for feedback, educating staff, and changing the attitudes concerning fall prevention. Result. Authors concluded multi-component fall prevention program can successfully reduce patient fall by as much as 30%. So my thought for this research article is the study shows that if properly implemented, a guideline such as prevention of falls can be successful. So now it's come to my last evidence-based practice article. The last one is inpatient falls, defining the problem and identifying possible solution, part 1. And evidence-based review. So the intervention for this research article is systematic review was completed searching for articles related to reducing fall interventions and inpatient fall prediction. Sample. The sample were from PubMed and Cohen Library Period to 2012. Detail. The author reviewed the statistical significance of intervention on fall reduction in study taking place in acute care hospital. Result. The author were unable to identify a single intervention that was effective in reducing falls. Positive results were probably the result of a multi-component intervention. So my thought for this evidence-based practice article is this is another study that shows multi-component interventions are more effective in fall reduction. After reviewing the evidence-based practice articles, I would like to make the following recommendation. So, how to achieve 100% compliance in application of prevention of falls guideline. First, retain neurology staff on major recommendation of prevention of falls guideline. Second, post prevention of fall guideline throughout the unit. Third, unit management such as charge nurses, unit director will perform weekly audit. Fourth, post weekly patient fall rate and non-compliant observation, no names. And the last one, the hospital should measure patient fall rate by using the standard fall rate of number of patient falls times 1000 and divided by number of patient days. Patient fall risk assessment must evaluate risk due to medications also. To do that by first, supplement Moss fall scale with Johns Hopkins fall risk assessment tool and assign highest predicted fall level. How to evaluate the effectiveness of the proposed recommendation. Compare 100% compliance to prevention of falls guideline by neurology unit versus before implementation of recommendations. Charge patients fall per month for 6 months before implementation versus 6 months after implementation. Evaluation criteria. The patient fall rate will be reduced. Compare patient fall risk assessment to prediction ability. Charge Moss fall scale result and Johns Hopkins fall risk assessment tool results versus patient falls for the 6 months after implementation. Evaluation criteria. Ability to predict patient fall risk. What do we expect to achieve by implementing this project? implementation of the Prevention of Falls guideline. Second, 100% compliance of Prevention of Falls guideline by neurology nurses and nursing techs. And the last one, reduction of inpatient falls in the neurology unit to below 1.3 to 8.9 falls per 1,000 patients day. Here are some key points I would like for you to take away with you. Current inpatient fall rate for the neurology unit is unacceptable. The research say the neurology unit can do better by properly applying evidence-based practice. Need better patient fall risk assessment tools that includes medication and using the Johns Hopkins Fall Risk Assessment tool as a supplement may be the solution. Permanent fall reduction will take teamwork. So does anyone have any question? So now we come to the last slide. This is my reference page. And thank you everyone.